Hello ladies and gentlemen, and welcome for the first time a live stream of the wrap-up of the Thorax Center of one of the major cardiology meetings. And today we're going to wrap up the latest ACC 2020 meeting. That was a virtual meeting, really a historical meeting. And as always, I will do this wrap-up with my good friend and colleague Joost Daemen. We are at the end of a busy day in the cath lab, so that's where we are situated now. This is one of our brand new cath lab rooms, and in this setting we will discuss some of the highlights of the late-breaking trials of the ACC 2020. I do hope you are well, safe and healthy and motivated to hear about cardiology. So Joost, let's first start with the Taylor PCI.
Yeah, so welcome everybody. So as Nicolas alluded to, we will try to focus a little bit on the late breakers that we selected that could be of interest to you. And we'll elaborate, as always, a little bit again on the results of the studies, and also on the implications to us, and on the things that stood out from a methodological or conceptual perspective. So the first study that we want to discuss was the Taylor PCI, which was a randomized controlled prospective study in over 5,000 patients presenting with either ACS or elective PCI that were randomized to either a conventional strategy using clopidogrel in all patients, so not really conventional, but at least control in this study, versus a CYP2C19 loss of concept genetic testing arm, in which all patients that had a lot of loss of function allele were not treated with clopidogrel but switched to ticagrelor. So interesting in this study, so they were all followed for an ischemic endpoint of death, stroke, myocardial infarction, stent thrombosis, or new hospitalization for ischemic events at 1 year. And the trial was very, very powered for aiming for superiority 50%, so quite aggressive, I would say. So when we looked at the results, several things were quite remarkable. First, the study found and actually confirmed previous studies that actually 35% of the patients had this loss of functional allele gen mutation, which makes it, at least to me, a relevant thing. Second thing is that they made comparisons between the baseline characteristics of the groups of patients with the loss of function versus those without the loss of function gene mutation, and found that these groups were actually very well comparable. So there were no clear differences in patient characteristics in those with versus without the loss of gene function gene mutation, except for patients from South Korea, or maybe Asians in general, I don't know, that appeared to have somewhat higher percentages of these genetic mutation as those, for example, in Europe or the US. Interesting then is that the study at the end didn't compare two arms of 2,600 patients, but only compared the 900 patients, so the 34% of the patients with a genetic mutation in the control arm, versus the 900 patients in the active arm that had the gene mutation and were switched to ticagrelor. So at the end, a study actually that compared ticagrelor versus clopidogrel in 1,800 patients with 84% of the cases ACS and 16% stable angina. What then the trial showed is that the MACE rate at 1 year was 4% in those who switched to ticagrelor versus a 5.9% incidence at 1 year in those who were still on clopidogrel. And with that, the trial just did not meet its primary endpoint with a p-value of 0.06. Despite the fact that was a least adjusted hazard ratio of 34%, so that's 34% less risk of the primary endpoint at 1 year. A pity, but to me still of interest. The majority of the benefit was seen in the first 3 months, but thereafter not that much change. So my take from this study is that it confirms the potential of genetic testing, since it does make sense, since 34% of the patient has these genetic mutations. On the other hand, I'm not sure that this data will be sufficient to actually start implementing this in routine practice, specifically not with the findings of this particular study, in which 84% of the patients had an ACS. And in our practice, and I think everywhere in the world, would be treated with prasugrel and ticagrelor anyhow. So then it would become less of an issue.
So I thought it was a very interesting trial design, especially as it also included stable and unstable patients. 80%, as you mentioned, were ACS patients, so around 20% had stable disease. And I was wondering, okay, is it of interest to start to think about ticagrelor in patients with stable disease, right? And stable and elective PCIs, because basically that is not according to the guidelines. Unfortunately, I think the numbers were too small to get any formal indication whether we could move into that direction. On the other hand, in terms of genotype testing in clinical practice, I do see that there might be an interesting application, especially since we are moving to patients who will eventually receive single antiplatelet regimens, especially early in their treatment strategy. So I can imagine that if you would have patients on oral anticoagulant drug therapy and you would only add clopidogrel, for instance, you may want to know that the patient is a clopidogrel responder, right? Because otherwise there is no antiplatelet coverage at all. So I think in a subset of patients who are on oral anticoagulant drug therapy, where the field is already moving to single antiplatelet drug therapy, and maybe in patients with ACS, there might be an application, I would say.
I agree. That is food for thought for the future. Let's move on to another trial on drugs. In this case, a subgroup analysis of the Augustus trial. So you all remember the big New England study on edoxaban. So it was a study with a 2x2 factorial design enrolling over 4,500 patients with AFib. So we had an indication to oral anticoagulant therapy, to either vitamin K antagonist or apixaban, versus in this 2x2 design to either aspirin or placebo, on top of clopidogrel for 6 months. What the investigators found is that in the primary analysis, which was as published in the New England, that adding aspirin significantly increased the risk of bleeding. A very consistent finding also in all of the other studies of this sort. But on the flip side, they also found that adding aspirin, specifically in the earlier days, might reduce ischemic events. So that was exactly what this subgroup analysis was about, to look at the potential additive effect in terms of reducing ischemic events at the trade-off of increased bleeding in this particular trial. So for that, they came up with, let's say, 2 different endpoints, one for bleeding and one for ischemia, in order to get a sort of a matched comparison in terms of a bleeding and an ischemic endpoint that would be more or less balanced in terms of impact to the patient. And what they found was that at 30 days, the addition of aspirin added a 1% risk of, let's say, bleeding in this, with this definition, but also reduced the risk of ischemic event with 1%. So with that, it balanced out a little bit, or at least to some extent. But after 30 days, the addition of aspirin only added a bleeding risk, while it didn't actually translate it into a reduction in ischemic endpoints. So an interesting observation, which should be put into perspective to the design of the trial, in which most patients actually were preloaded with aspirin. So the per-procedural benefit, I would suggest, was there in all of the patients. And finally, I'm not really sure how whether this analysis will make us reconsider adding aspirin to our standard dual strategy of the vitamin K antagonist or NOAC plus clopidogrel in these patients, on top of all the studies we know thus far, like Pioneer, like Joost, like Rejewel, etc. So if this will reopen the discussion, I'm not sure, but at least it helps us to at least appreciate where the risk of the aspirin is in these patients.
But at the end of the day, this was not a big surprise, right? The study results were not a big surprise. We already had the signals that probably moving from a triple therapy to dual therapy, oral anticoagulant drug therapy with clopidogrel and monotherapy might be associated with more stent thrombosis. But it never has been a statistically significant finding. And I think, at least in our center, we typically do dual therapy, so either a NOAC in combination with clopidogrel or vitamin K antagonist with clopidogrel. Only surrounding the procedure, so per-procedural, we always give still aspirin, right? So the patient will be discharged without aspirin, but during the procedure, there will be aspirin and clopidogrel on board.
Yep. I agree. So let's move on then.
Yeah. let's maybe talk now a little bit about structural heart disease. We were quite enthusiastic in our preview about the popular TAVI cohort B trial that would be presented at the ACC, and the virtual presentation was not too big of a surprise to me, but there were some interesting observations. First of all, the study evaluated or enrolled 326 patients, predominantly in the Netherlands and in Belgium, and patients were randomized to clopidogrel on top of oral anticoagulant drug therapy in patients who underwent TAVI and had atrial fibrillation, thus required oral anticoagulant drugs. So there was one arm with the combination of oral anticoagulant drug therapy and clopidogrel, and then one arm only oral anticoagulant drug therapy. Turned out that the mean age of the patients in this trial was 81 years old, STS score of 3 point something, so basically a more intermediate to high risk patient population. Why I would say high risk? Because an STS score of 3 in combination with an age of 80 years old, these patients are typically tend to be more frail and have some comorbidities on board as well. I think the findings, the final results were important, but we should put them in perspective because only 1 in 5 of the patients were on a NOAC. Yeah. So the majority of the patients were on vitamin K antagonists, and we already predicted this, that that would be the case in this trial, and this already deviates from current practice. In this day and age, I think for atrial fibrillation, we would always prescribe a NOAC, and we have a choice of four drugs there. But vitamin K antagonists are more or less restricted to other indications, I think, at this point in time. But still, when you added clopidogrel on a vitamin K antagonist, or in 1 in 5 of the patients a NOAC, you ended up with major bleedings in 1/3 of the patients. If you would drop the clopidogrel, so you keep the clopidogrel away, the major bleedings were in 1 in 5 of the patients. So 20% of the patients had a major bleeding at 1 year. I think the end result is not so novel, but nobody had made this observation in a scientific way. So I think that is the forte of this trial. I think Joost and the group in Mieghem, they need to get a lot of credit for designing these trials that are intuitive, but also make total sense from a clinical perspective.
Very clinically, very relevant, I fully agree.
Yeah, and we all know, I think, that there is also a cohort A. This cohort A is anticipated in the back end of the year, so probably around one of the big meetings, if COVID-19 allows it, at the end of the year. And that, of course, will look into the effect of clopidogrel on top of aspirin in patients who do not need oral anticoagulant drug therapy, but undergo TAVI. So I think that is another big trial and an interesting trial that probably then, if we do the math, will include up to 700 patients. Cohort B was already published in the New England Journal. I think they are on a good stride there.
Good way for cohort A as well, yeah.
Yes. I think we also need to keep in mind and keep an eye on other trials on oral anticoagulant drugs in the TAVI space. And I think the most important one that comes to my mind is the envisaged TAVI AF trial that, again, has completed its enrollment early this year. And the trial results will be presented sometime Q1, Q2 next year.
Yeah. For this trial, Nicolas, what stood out to me is that still this also is a call for a need to improve how we manage our vascular access. 22% of the patients had vascular access complications, which accounted at the end for most of the bleedings. Yeah. So that's I mean, for a trial which was, I think, particularly performed in the Netherlands and Belgium, leaves room for improvement. It
does leave room for improvement, and I must admit, I'm not aware, or I don't have the exact protocol now on my mind, but I believe that vitamin K and the NOACs were interrupted for the TAVI procedure.
I don't know either.
So the patients were put on heparin. So, but again, 20% is a high bleeding rate. I don't recognize that from our practice, and don't forget the patients were enrolled in 2014 and after. I think the vascular complication rate in the major low-risk trials are definitely lower, are around 5%. But still, there is a need for even improved access site management when you are doing procedures with large bore catheters, and this is where novel access closure devices, so large bore closure devices, come into play, and we have several trials on that ongoing and ended lately. Basically, a randomized trial comparing a plug-based closure with suture-based closure, the Manta device versus ProGlide, and also a large Manta registry that was recently presented at the CRT meeting. So I think access site management is so important in TAVI. We were talking about oral anticoagulant drugs after TAVI, but there was also an interesting trial from Korea that we wanted to highlight. DNAVL, yes. So that was a relatively small trial that compared edoxaban, so one of the NOACs, with vitamin K antagonists in patients who required a bioprosthesis, a mitral or aortic bioprosthesis, or a mitral valve repair. These patients were all randomized to either 3 months of vitamin K antagonists or 3 months of edoxaban. And the trial, in my eyes, was so underpowered. We had 100 patients in each group. There were hardly any clinical events. There were numerically more events in the vitamin K group, but this was so small, and it was also a mixed bag. 50% of the patients had an aortic bioprosthesis, 50% of the patients had some kind of mitral valve intervention. I think it's interesting, and I do believe it makes a lot of sense to investigate and to look further into the value of the new oral anticoagulant drugs in patients after surgical or transcatheter aortic valve replacement, but we need numbers.
Yeah, I agree.
Yeah,
I agree.
Okay, next up was the Venous trial.
Yeah. So the Venous trial, so that was it was a little bit of a peculiar trial for us to discuss, since it was a trial obviously definitely alluding to the EP field, which is not our key area of expertise. But it stood out because of the strategy that was chosen in this trial, which matches a little bit one of at least my personal interest, which is managing the sympathetic nervous system in order to improve diseases that are related to sympathetic nerve activity. So the Venous trial was a randomized controlled trial enrolling over 300 patients, which were with AFib, with persistent AFib actually, that were randomized 1-to-1 to either routine pulmonary vein isolation versus routine pulmonary vein isolation plus vein of Marshall ethanol ablation. So as alluded to in the preview, the vein of Marshall is a small side branch or a side branch of the great cardiac vein that can be accessed through the coronary sinus and does the drainage of blood from the right atrium. And that's exactly the area where many of the repeat AF recurrences come from in patients with failed PVI because of perimitral flutters. So this study randomized patients to a vein of Marshall ethanol injection in order to, let's say, damage the nerves there that might play a role in the recurrence in terms of perimitral flutters. And what the authors actually found is that first, 85% of the cases, they actually managed to do the ethanol infusion in this vein, which to us was interesting because we were alluding to the fact that there might be a lot of interpatient variability and how these veins go and pass and what the size is, etc. But still, 85% I think is a number that is definitely not bad. And that was achieved by adding approximately 30 minutes to the procedure time. So these guys still take 3 to 4 hours for doing these procedures. I think that is something to take in mind, specifically if you look then at the success percentages, because at the end they were able to achieve an ablation success in 38% of the cases in the PVI alone group versus 52% of the cases in the PVI group plus the vein of Marshall ablation, and that was defined as the lack of AF episodes larger than 30 seconds at 3 months. If you added repeat procedures, those numbers went up to 50-60%, as we know from the previous PVI literature. So as mentioned, to me of interest, since this again shows that adding a interventional procedure that modifies the sympathetic nervous system at some point in some way is also in this, again, randomized controlled trial, efficacious in adding to the effect of a procedure we already know, like in this case, pulmonary vein isolation. On the other hand, it also illustrates that procedures like PVI definitely haven't achieved their end goal yet. I mean, the numbers of success are still disputable. It's still a procedure in which has never been prospectively investigated in a double-blind, sham-controlled, randomized trial. So I think also our EP friends have still some work to do in improving their practice, but an interesting concept.
But at least there's creativity.
Definitely.
That was to me the striking part of that study.
Yeah.
Okay, let's move on to the Medtronic TAVR low-risk bicuspid study. That was also highly anticipated because we had some remarks related to that study. Just in a nutshell, these were 150 low-risk patients with proven bicuspid valve disease. And that was a little bit striking to us because, of course, in principle, these are the patients that need to be referred to surgery. There are no randomized trials to back this kind of practice, to back up this kind of practice. And still, we now had a prospective study. It was not randomized, but quite of interest. And I think they did a very good job identifying 150 patients with proven bicuspid disease, proven by CT scanning, but 1/3 of the screened patients were excluded. So then the question is, okay, but why were they excluded? Well, the main reason were aortic dimensions, either the ascending aorta or the annulus itself. The sizing was based predominantly on the annulus by CT scanning, so not based on the intercommissural distance or other kind of new funky dimensions that are out there for bicuspid. So strictly based on the annular sizing, like we do with tricuspid aortic stenosis. And the patients had to, or there was a recommendation to do a pre-dilatation. So what was interesting is that the results, the hemodynamic results of this valve in bicuspid patients was amazing. Yep. The valve area was 2.3 centimeters square, which is huge. It's even larger than was presented in tricuspid, in the tricuspid space in the low-risk trial. So that was striking to me. But we have to bear in mind that 40% of the patients received the Evolut XL, which is of course the bigger valve, 34 millimeters inflow portion. So the constrained area is smaller, is around 25 millimeter, but still the hemodynamic performance was exceptional. The downside, as expected, 40% of the patients had mild PVL, 2% of the patients had moderate PVL. So it is still out there, and we all know that even mild PVL is now controversial. Is it related to outcome or not? So whether
specifically in patients with an average age in this study of 70 years.
Exactly. So they should have a long life expectancy of at least 15 years. So if mild PVL is relevant in clinical practice, then you would not want to have that. What was also of interest, in my opinion, was the neurological event rate. That was 4%. Major disabling stroke, very low, I think 1%, and the remainder were minor strokes. But still, it is important. They were all procedure related, and I wonder whether they were using cerebral embolic protection devices in this trial. We, of course, we do it typically in all our patients. Whenever it's anatomically feasible, we would protect the brain of our patients undergoing TAVI, and especially in these younger patients with anatomies that are heavily calcified, I think those are the patients that you would definitely want to protect, right?
Yeah.
Okay, so that was the Medtronic low risk. We have spiral HTN off meds. What about renal denervation?
Renal denervation. So spiral HTN off med is the study, the pivotal study of Medtronic that many of us have been waiting for. It is the let's say successor of the pilot results that were published already almost 3 years ago, August 17. So now we are almost 3 years later. So that's the time it took to enroll finally using a Bayesian design 300 patients. So remember, in the pilot there were 80. In this study there were 300. So the study finally was powered for efficacy in showing that renal sympathetic denervation using the Medtronic spiral device is superior to a sham procedure in reducing systolic 24-hour ambulatory blood pressure in patients with an ABPM of above 140 but below 170. So all of them had to be taken off drugs. Unfortunately, the trial was positive. So that is the brief version of the discussion of this trial. The delta in blood pressure was 3.9 millimeters of mercury. So that's the average delta in 24-hour ABPM. So taken over the full 24 hours was 3.9 or 4, depending on the definition, millimeters of mercury as compared to sham. So a number that is consistent, very consistent with the solo trial of RECOR, which showed the delta 4.1, but it's not impressive. I mean, it's 4 millimeters of mercury, which is also lower than what was seen in the pilot trial, which showed a delta of 5.5 millimeters of mercury. Now it's 4, but it's ambulatory. On office base, it was 6.5, which fits with the effect of more or less of one drug. So again, this study adds to the data we have on renal sympathetic denervation. It again proves it works. I think we passed the stage of disputing whether it works or not. We've seen also with this trial that in a very controlled setting, in a population that is as pure as possible, also in this study, 91% of the patients actually remained off drugs during the course of the follow-up. Which is a very good thing, and at least taking the drugs out of the let's say, confounder part, the therapy appeared successful and effective. But as mentioned, it's a steady effect, but not impressive. And I think there is still a vast need for future studies in more real patient population that take into concern all the lessons that we learned in terms of confounders from a procedural perspective and from a patient and drug perspective.
But at the end of the day, I would still want to encourage believers in this therapy and also the physicians and the experts who are involved in this field, including you, to keep on going, because it does work. And I think that is the major takeaway for me. It's maybe not perfect, the technology as we know it today, but it is a matter of time. This will become an established
The biggest challenge will be at the end to find where in our spectrum of treatment armamentarium this therapy will get a place in which patients, at which state, and at the end it will be a matter of applying routine practice according to guidelines that remain imperative and intuitive for all of the cases we see in daily practice. But at the end, there are still a lot of patients in which we simply cannot apply guideline-directed therapy because patients don't want to take the drugs, because they don't understand how to take the drugs, because they don't tolerate the drugs. There might be a strong preference of the patients not to take drugs. But specifically, if they're higher risk, I think they need therapies like this in order to improve blood pressure control and subsequently long-term outcome.
Yeah. Okay, let's move on to the last two trials that we want to highlight. First, the UK TAVI trial. Let's stay brief. I think there were more than 900 patients enrolled. Mean age was 81. Yep. I think you could call them intermediate risk patients with an
STS 2.6.
Yeah. So it was more or less a potpourri of devices, of TAVI devices that were compared with surgery, one-to-one randomization, and the outcomes were not shocking. It was, TAVI ended up being non-inferior. There was more PVL with TAVI, but more AF with surgery, and at the end of the day, there was no difference in their primary endpoint at 1 year. Not much novelty there. Maybe a cost-effectiveness analysis that was anticipated might provide a little bit more of more interest, but we will stay tuned for that because I hope that the UK TAVI trial will deliver some more information down the stretch. And then just as a takeaway, the Victoria trial. Vericiguat, if I explain it properly, is a new product that enhances ventricular function and vascular function. It increases the levels of cGMP, and then by doing so, you improve cardiac function and hopefully also the vascular function. It was a it was studied in patients with heart failure who had a recent deterioration. And the deterioration was a hospitalization or an admission, one-day admission, where they needed IV diuretics. Patients were selected because they needed to have a systolic blood pressure above 100. They needed to be off IV therapies. And they managed to enroll more than 5,000 patients, and they had an absolute reduction of more than 4% in their clinical endpoint, which was a composite of cardiovascular death and heart failure hospitalization. I think this is the next one in a series of new drugs, innovative drugs in the heart failure with reduced ejection fraction patients. Yeah. But it starts to become confusing to me because now it's already a jungle of anti-diabetics that you need to use. Remember the DAPA-HF at the ESC last year? Yes, and now we have another drug. So how will we incorporate all that on top of Entresto, on top of beta blockers, on top of maybe MitraClip in patients with functional MR and HFrEF? So somehow, someday you would like to have some clarification from experts and also some consensus. How do we need to apply and incorporate these new treatments, and how will we make it cost effective and also manageable from a society point of view? With that, I think we discussed the trials that were of interest for us at least. There was much more trial activity ongoing at this interesting virtual ACC meeting, but at one point you need to be selective and you cannot follow everything or present everything. Anything else you want to add, Joost?
No, I think we covered what we wanted to cover. We would like to thank you for watching during this first live transmission for Radcliffe.
It's a different dynamic. Still, we are in the midst of a COVID pandemic. Please be safe, be healthy, follow the recommendations of the authorities, and hopefully we can get beyond this pandemic in the following months. So thank you very much for your attention. Thank you very much for following us, and we hope to see you along the way.
Thank you. Bye-bye.